This conference will now be recorded.
Hello all, I am Ali and we are going to talk today about some of the important tasks that may come in the November exam. First of all, I hope all the best for the people who are going to November, and we will not talk today about the module of the exam. How is the module, what is the module, how you can tackle this module in the exam. I think all of you have gone through this already, and you are now on the time of practice. I think you have only less than 1 month, so this month I think it will be enough for you to practice and to repeat the task again and again. Don't waste your time to read more and more tasks, new tasks, and I think it will be better if you revise the tasks that you already discussed, revise the recall, because they keep coming, keep bringing the recall, repeat the tasks again and again. So most of the exam will come from the recall, about 10 to 11 cases. And if they bring 2 or 3 cases new, I think if you put a template for yourself, you can tackle this and you can answer this quickly and easy. I want to give you some small advice for all of you. If you are in the exam and you face a new task or a new topic that you didn't cover it before, don't be anxious and don't worry. You can take mark for this task. How can I take mark in this task? By information gathering, organized and systematic organization of the history of information gathering, and be safe, doctor. If you tackle the safety point in this task, and you do a good communication with the patient in this task, you can pass in 3 domains, and only there will be only one left domain, which is applied knowledge. It can be uh, covered in another module. It can be reached by the other modules. So don't worry if you find in the exam a new task or a new scenario you didn't practice it before. Don't worry, it will be the similar, okay? Because no one can cover each topic in the world, each disease in the world. See, sometimes they bring a new disease for you, like Albert syndrome, like Charcot-Marie tooth, like talibus, like echogenic bowel, any new things for you, renal transplant, any new things. No one can cover all the disease, so it will be the same. If you put template for yourself, it will be the same. Take information, take in history in a systematic way as you used to do, okay, and talk with the patient about the effect of the disease on the pregnancy and the effect of the pregnancy on the disease if it in the antenatal and the maternal medicine module. Okay, then go to the suggested plan. I wanted to tell you that you still can pass in this task, or at least pass in 3 domains in this task, if you don't know anything about it. Okay, and this happened and it will continue to happen. Okay, so don't worry about that. My advice for you now is to keep practice, repeat again and again the recall, repeat again and again, and please try to read also the green top guideline and the nice guideline related to the task, okay? Because the applied knowledge will give you confidence in yourself, okay? And also sometimes some point in the patient safety should come from reading this guideline. So if you put for yourself a very short time, 10 to 15 minutes for repeating the guideline related to the task, okay, and this will be much more enough. No time now for reading the patient information leaflet. You can see some of the videos, like strategy videos, like Lisa Joel videos, if you have these videos, okay, to know how they do, or to see how the candidate can tackle the scenario in the exam. Okay. I want to go direct to the scenarios today, the tasks today, not to waste your time. I wanted to today to take as much of the tasks as we can. Okay, please, we can differ or postpone any question, any discussion after we finish the session today, not to waste the time of the other people who want to practice. Okay, so if you have any question, we can discuss this in the group or after the finish of the session. Okay, so let's go to the first one. I will try to give. I cannot say most of you or all of you today because the time will not allow you. But if I try to take to the one who sent for me first, and the other one, I will try to do another session. Okay, and to give the opportunity or the chance for all the people or most of the people to practice. Some person sent for me the name, but I cannot. Uh, uh, I don't know what is the name. It is not written here. Like Dr. Nairuz. Dr. Nairuz sent it for me on the chat. Nairuz. Okay. Dr. Manikam.
Good morning, sir. I'm ready, sir.
Okay. If I say the name right, correct?
Correct, sir.
Okay. Good. Okay.
They call,
Manikam. Okay.
yes, sir. They call me as Money.
Many.
In
Okay.
yes, sir.
Okay. This is your task. I will adjust 2 minutes for you.
Okay, sir. Sir, shall I start, sir?
Okay. Good. I will adjust 10 minutes.
Uh, hello, I am Dr. Monicam, doctor in the EPAU clinic. May I confirm your name and age, please?
Sarah Smith, 32 years.
How you want to be called?
Sarah is fine.
Sarah, you have 48 hours before, I came to know that you have come with mild vaginal bleeding, and you had your last periods 6 weeks ago, and you had pain also. Now, how is your pain?
My pain now is fine, doctor.
Hmm. I came to know that your hormone level was 2900 then. Um, any other concern you want to discuss today?
No, doctor, I came since 2 days here, and your colleague examined me and offered me some tests and
Hmm.
a scan, and asked me to come today to repeat the test again. So
Uh,
I wanted to know the result of this test and what will be my plan of treatment.
before discussing about your scan report and blood test reports and your management options, shall I ask a few questions to know more about you? Then
Yeah,
I'll give you the. Then we'll discuss and come to a shared decision. How does it sound?
okay,
Uh,
that's fine.
please, Sarah, tell me about your condition. How does it started?
Yes, I started since 3 days when I have some pain in my right side,
Mm,
and this pain is going to my leg as well.
mm,
Uh, and also I have some spotting. It is not too much bleeding, it's just a spotting.
mm. Was it spreading anywhere? The pain?
Only to my right leg.
Has it subsided with the painkillers, or now do you have any pain?
It is still come and go.
Uh, okay, it is coming and going. And
Mm,
is there any burning while crossing V?
no,
Do you have any loose stools?
no,
Any fainting attack in the house? Did you have a felt any dizziness?
no, doctor.
Any shoulder tip pain?
No.
Uh, tell me about your periods. Were they regular? Please tell me.
Yes. My period is regular and last one since 6 weeks.
Mm. Is this a planned pregnancy or unplanned?
No, it is unplanned pregnancy.
Mm. Uh, did you use any contraception before, like intrauterine device like that? Any coil before? Not now.
Only we use condom, but at that time the condom break and the pregnancy happened. I have missed the period, but it is welcomed.
Oh. And one more thing I want to ask is, you may find it intrusive. Shall I ask you?
Okay?
Have you been ever treated for any sexually shared infections?
No,
Any treatment for pelvic infection?
no,
Uh, have you been pregnant before? You had one child, I think. Was it? What is the age of your child?
a 3 year.
Uh, um, how is he? He or she? I do not know. Is she fine?
Tom is fine, yeah.
Mm. Uh, do you have any medical condition for which you are treated by a GP?
No,
Do you have any allergies?
no,
Are you on any medications?
no.
Any surgery in the past?
Yes, I have a surgery for appendix.
Oh. How did you recover?
It was fine.
It was by open surgery or keyhole surgery?
It was by keyhole.
Uh, uh, do you have any family history of any specific condition like clot formation?
No,
Hmm. Do you smoke?
no,
Do you take alcohol?
no,
Pardon me, any recreational drugs?
no.
Are you aware of your weight to height ratio?
Yes, it is 28.
Hmm. Uh, do you know your blood group?
And it is O positive.
O positive. Any reservation against transfusion?
No?
How are you supported in the family?
Yes, my partner is very supportive. He loves
Hmm.
me so much.
Hmm. Do you feel down, depressed for the past 4 weeks?
No, at all.
Hmm. Uh, um, Sarah, I want to thank you for the information you have provided. Do you want to add anything?
No, at all.
Uh, I want to examine you in presence of chaperone with your consent, and the blood pressure, heart rate, temperature will be recorded by the specialist nurse. Sarah, mm, I have verified your name, NHS number, and age with your reports.
Okay.
The pregnancy hormone level has shows a rise, but it is not up to the mark. And are you alone?
Why, doctor?
Um, I have a concerning news for you. I do not have a good news. Sorry. Uh,
What
shall I
happened?
ask shall I ask the specialist nurse to be with you for support?
No, no, doctor, I can manage. Can you tell me direct what happened?
Mm. I'm really very sorry to be the bearer of the news,
No, no, no. What?
Sarah.
Mm.
This first scan showed not, it was inconclusive, but the second scan shows in the right side there is in the tube there is a small mass measuring 2.7 centimeter. At the womb is empty, and the pregnancy is there. Therefore, it is occurring in the right tube. It is called we call it ectopic pregnancy. The
Oh,
pregnancy occurring in the tube.
oh my God.
I'm
Oh my
sorry
God.
to be the bearer of this news.
Oh my God. Oh, oh my God, my baby. Mm. Oh my God. So, doctor, any method to put my baby in my womb?
I'm able to see that you're in a distress condition. I'm sorry. It is a abnormal position. It cannot grow there. This tube is very small structure.
Why,
Due to
doctor?
some,
Why?
mm, you had one surgery before. No, that should have gone for some organs stucking to each other. That has prevented the movement of the tube. Usually, the baby is formed in the tube. I'm showing you with the diagram. So, the baby is formed in the tube and it gradually comes down and to reach the womb. As the movement is disturbed because of this organs getting stuck to each other, it has stayed there itself, I think. As you do not have any sexually shared infection or smoking, these factors are not there. So this should be the reason.
Okay,
So,
so what happened next, doctor?
uh, but it is not show. It's not showing any heartbeat. That is a good thing. Your care will be. We are here to help you. Do not worry, Sarah. Your care will be under the care of the consultant led unit under care of the group of specialists, including my consultant, specialist nurse, the imaging doctor, the hormone doctor, the physician, the pain doctor, and the mm,
Okay.
psychological counselors and support groups are also there. So, after running some tests, that is to find whether your uh, liver is working well and kidney is working well, and whether you are anemic to find a full blood count. And after this, if you can come for follow up, uh, there are three methods of treatment usually. One is the medical treatment and other surgical treatment. Other one is the conservative management. It is not possible in your condition as the levels of hormones are high. So, if you are wishing, you'll be offered the medical management. The other one is the surgery method. If you can come for follow up, medical management can be followed. Shall I explain that to you?
Yes, please. I wanted the medical
Mm.
one. I don't
Uh,
have I don't want
mm.
to have surgery.
Uh, According to your weight, the injection methotrexate will be given in the muscle. Uh, as you have received this, done this test now, after running this liver test and kidney test and a full blood count, this injection will be given and you will be asked to come for on the day 4 and day 7 for again the measurement of the pregnancy hormone. And if it falls less more than 15%, you will be allowed to continue the treatment weekly once this measurement will be done. This will go for shrinkage of the pregnancy tissue. And there may be some side effects. You should not take any alcohol and you should not go in sunlight and should avoid intercourse or heavy exercises. Am I clear so
That's
far? Mm.
but
Some
you
may
make
develop some nausea, vomiting,
okay.
uh, and this will come to normal.
Mm.
Then, uh, if it does not fall more than 15%, then the scan will be taken to find any heartbeat of the baby, and the consultant will review you. And if there is no heartbeat, she'll be offering you one more injection, and again it will be followed with a weekly test. Am I clear?
Yes, you are clear, doctor.
Otherwise, if the baby's heartbeat is present, there's no other go. We have to opt for a surgical management, and only 7% require surgical management, 7 in 100, whereas 15 and 100 may require injection, second injection. And women who receive this injection are advised to follow some contraception method, safe, reliable contraception method for 3 months, so that this medicine goes out of the body and the other pregnancy will be safer. Am I clear? And there is a
Yes,
chance. And one
yes,
more thing I want to tell you, you're not able to, you're not asking any question. Am I clear so far?
yes, doctor, you are clear.
Mm. Mm. I want to tell you, there is a chance of recurrence in the next baby also. So when you get pregnant next time, mm, as you had one history of surgery, appendectomy, and now you had an ectopic pregnancy, so you should come early in the once you miss your periods to come for a urine pregnancy test. And if it becomes positive, you should be advised to have a scan at about 6 weeks, so that we can find out at early stage if it occurs. The chance is a little more. No, usually it occurs in uh, 5 to 7 in 100 women. So if it happens like that, it can be detected early and it can be treated with medication. So that only you are advised to come earlier. And if you are when you are given this medicine and you are going home, to develop any increased pain in the tummy or any dizziness, should be having good support in the home, so that somebody should be there to bring you immediately to the hospital for medical help. Am I clear so far?
Yes, you are clear, doctor.
Do you have any doubts, Sarah?
No,
Um, mm, do not worry, we are here to support you. We'll do all the needful for you. I'll give you the patient information leaflet. I'll document everything, and I am writing back to your GP. And now you are being offered this test. The specialist nurse will take the blood samples for your test, and after reviewing this, my consultant will examine you, and she will give you this injection. Do you have any other question, Sarah?
no, no, thank you.
Uh, uh, Thank you, Sarah, for your time.
Thank you. Thank you, Dr. Manny. Well done. Excellent, Dr. Manny. You did the task in an excellent way.
Thank you, sir.
You take every point in the task, to be honest.
Sir,
Uh,
in Tamil, they used to say a ringed finger. You only started, sir. I first presented the case only to you, sir. That is the first hit with the finger wearing a golden ring. Like that, I got hit from you.
okay,
So I am getting reward from you. Thank you, sir. Thank you so much, sir.
thank you,
Please
thank
bless me, sir. Bless me, sir. Thank you.
you, thank you very much. Well done, excellent. You did the task in an excellent way, but the problem is the time management. So, as we
Mm,
know,
mm.
any point you will mention after the time, you will not take any point about this. You will not take any credit
Okay,
about
sir.
after finishing the time. They will
Mm,
even they will not allow you, even if
okay.
the and the face and face
Mm,
exam
mm.
or in the Osler, they will not allow you to talk after that. Okay, and it
Mm,
will be also something not good to
mm,
stay in the cubic if you are in the face and face is still
mm.
talking after the time. Okay, so the problem, as you know, the time management. So try
Yeah.
please to finish within the 10 minutes, and you will
Mm.
come by practice again and again,
Okay, sir.
okay, to try to finish that in the 10 minutes. But otherwise,
Mm,
you managed the task in very nice way. Your communication with the patient usually start by communication, because communication in part 3 is the most important domain in
mm,
part 3 exam.
mm.
Okay, so communication is perfect. Your lay language is very good. Your sympathy is perfect. You give information in small chunks. You check understanding. I think you draw. Did you draw?
Yes, sir.
Okay, good.
I told you as if I'm drawing.
Yes,
Sir, I'm going for face-to-face exam, sir.
yes, good, good. So, okay, this is the best example to draw. Ectopic pregnancy, the best example you draw. If you didn't draw in the ectopic pregnancy, you will not draw for any other task. So drawing is very important, okay?
Yes,
Especially the face and face exam. So your communication with the patient is perfect. Regard to the patient safety, the second important domain of patient safety is perfect. You take all the point for the patient safety regarding to the contraception. If she received the methotrexate, the warning sign, even you warn her about the warning sign when she go home, when she should come to the hospital immediately, and even in the next pregnancy, you warn her about the next of the possibility of the recurrence in the future pregnancy, the blood group, everything you in the patient safety to witness. Information gathering was organized, systematic, okay, and you the best thing is that you ask about the history of present illness, which is the symptoms and sign of ectopic pregnancy in details to check for the patient safety, if the fainting, attack, deep pain in shoulder, amount of the bleeding, everything. So information gathering also was organized, systematic, and you cover all the points. You cover the surgical, which can be a predisposing factor, the sexual history, which is may be a predisposing factor, the smoking, which may be a predisposing factor, everything. Only you can stress please on the contraception because this is unplanned pregnancy, so please stress on the contraception. If she doesn't want to have unplanned pregnancy or after this event, she should use a reliable method of contraception. Okay, so
yes, sir. Sir, one thing I have forgotten, sir. We should avoid intrauterine contraceptive device, no, sir. That I should have told.
Intrauterine device increase the risk of ectopic pregnancy, increase the
Yes,
risk
sir.
of ectopic pregnancy. Okay, so you should stress on the stress on the reliable method of contraception. So this is I want from you to stress on this point.
Okay.
Applied knowledge about the ectopic pregnancy. Your applied knowledge is perfect. Okay, so you know that there are three in general. There are three methods of managing the ectopic pregnancy, which is a conservative measures. Wait and see, give the nature time to take its action. Okay, it is the conservative method. The second method is the medical management, which can be by the methotrexate, and the last option, the surgical method. You know from your the NICE guideline, the wait and see or the conservative cannot be offered here because the beta HCG is high, so this cannot be offered for this patient. So she still have two options, which is the medical option and the surgical option. The patient prompt you, she doesn't want to have surgical. What I suggest for all of you, if you have a list of options for the patient, any patient, there are a lot of options can be offered for the patient, and no one can cover all the option at all. For example, in this one, in the patient with menopause, in the patient with PMS, in the patient with station incontinence, urge incontinence, there are a lot of options can be offered for this patient. So how can we do that? I suggested to mention the broad line of the option in the start and ask the patient which one you wanted to start, which one you wanted to know more. Okay, she may prompt you to mention about the medical, she may prompt you to talk about the surgical. Okay, so you are now save your time because no one can cover all the options listed for the treatment of a huge thing like that. Okay, so this patient prompt you to talk about the surgical because the time cannot allow you to talk about everything in the medical and surgical. You talk about the medical in the nice way. So the medical can be methotrexate. Some side effects of this methotrexate like sore eyes or mouth, chest and abdominal discomfort. She will stay in the hospital over the night, and they may come again on day 4 and day 7 to repeat the beta HCG. If a drop of the beta HCG by 15%, she will continue weekly till back to come back to the normal. But if it not drop by this percentage or by this way, so she may need another dose of the methotrexate. Very important thing that if she feel any pain, any bleeding, feeling unwell during this period, she should come back to the hospital immediately. Okay, and she should use a reliable method of contraception for at least 3 months. If the patient choose the surgical, you know how to counsel her about the surgical. Sure. Okay, so it will be done by a keyhole surgery, and there are two methods of the surgical: either to remove the tube by the pregnancy, it's called salpingectomy, or to remove only the pregnancy if during the time of the surgery we found that the other tube is deceased. So it is called salpingotomy. If the patient offers salpingectomy, will offer a urine pregnancy test after 3 weeks. If it offers salpingotomy, you will do the beta HCG or the urine pregnancy test in a weekly basis till it drop back to the normal. Dr. Manny, very good, excellent. She talked about the future pregnancy and she warned about the risk of the recurrence in the future pregnancy. She may need an early scan, to check that the pregnancy inside the womb in that time. And at the end, you have to give the patient some patient information leaflet to read about the topics and give her contact number she should contact if she has any query or she have any emergency. Thank you, Dr. Manny.
Thank you, ma'am. Thank you, sir.
Thank you. Okay. Dr. Ahmad, are you with us?
Yes, I'm here.
Okay. Just 2 minutes.
Okay.
Mm.
Okay, I'm ready for discussion.
Okay, let me adjust 10 minutes for you. And start.
Hello, I'm Ahmed, ready for discussion.
Okay, Dr. Ahmad, you have this patient in your clinic. She is a 24 years old with chronic kidney disease and she did renal transplant since 4 years. And she is now in your clinic. She keen to have a baby. So could you tell me what is the important point in the patient history you wanted to know about this patient?
Okay, so after introduction myself to the patient, I'm gonna take a brief history about her kidney problem. I'm gonna ask her, do you mind you tell me about your kidney problem to know more about what is why she had a renal transplant, any complications after this operation, which kind of medications she's following on, which kind of doctor she's following with, and if she's in a stable condition or not, if any recent flare or any problem with her kidney functions, and about her last visit to her doctor. I need to ask her about if she informed her doctor that she's wanted to get pregnant. So what's his recommendation about that? I need to ask her about any history of diabetes, because it could be diabetic nephropathy cause that problem, about her current medication, if she's got any swelling, any shortness of breath, any vomiting, any confusion, any difference of color of urine and amount of urine. I need to ask her about her obstetric history, if she got any pregnancy before, and if she got pregnant, how about if any complications, what is the root of previous pregnancies, it is before the transplant or not. I need to ask her about gynae history as well, just to check about her periods, if she's regular or not. Um, any up-to-date smears, any discharge, and any kind of contraception before. I need to ask her about any other medical history, if she got any other medical history like diabetes, controlled or not, any surgeries as well, just to make sure that it's okay for her. I need to ask her about her medication, she's taking folic acid or not, what is the dose of folic acid, any allergies as well. I need to ask her BMI and rhesus factor. I need to ask her about her family history and family history of inheritance. It could be inheritable disease, any social history, smoking, drinking, recreational drug. I need to ask her about her psychological history, mental history, if she got any depression or not. This is most what I ask for.
Okay, Dr. Ahmed,
Yeah.
this is the history of the patient. So can you have a quick read, please?
Yes. Yes.
Okay, so how you will manage this patient in the preconception period, in the antenatal and the postnatal period as well?
Okay, so pre-conceptional period, I'm gonna refer to just to liaise and discuss with her kidney doctor about her kidney condition, about suitability of getting pregnant at this time, because she's taking mycophenolate and tacrolimus linzoberine. I'm gonna discuss with her kidney doctor suitability to stop this medication or to shift this medication to more safe with pregnancy. I'm going to discuss with my consultant as well about this issue. I need to start her on folic acid if she's not on folic acid, and aspirin once getting a pregnancy. Once getting the pregnancy, I need to to arrange a follow up with a kidney doctor just to check about her blood kidney function. I can see here as a creatinine is a little bit elevated, and we need to arrange about some scans to check her tummy and uterus. She's taking Cerazette at the moment, which is considered many pills, reliable contraception. I need to continue until we decide to stop it to get pregnant. This is about pre-conception counseling. As regards getting pregnant, after getting pregnant, her care will be under multiple of doctors. So it will be under consultant, obstetrician, local transplant team, and a nephrologist, endocrinologist as well, a specialist midwife. During the first trimester, she will be it will be frequent visits, so we need to take her booking bloods to make sure kidney functions and to rule out any viral infection, and just booking screening. So we need to assess her for a VTE assessment from the start of pregnancy. She may start blood thinning medication, low molecular weight heparin, especially if she got high proteinuria. We need to check her renal function monthly, and send MSU as well to check about proteinuria. On the second trimester, we need to check about fetal anomaly scan and 20-week scan and serious growth scan, especially during the third trimester, to check about baby's growth. We may offer her, if she doesn't give her any history of diabetes, oral OGTT test at 24 weeks to check about diabetes. We need to at the end of pregnancy around 36, we need anesthetist to review her just to put a plan for delivery as well. um, um, We need in pregnancy we need to start her like I said on aspirin to avoid the risk of preeclampsia, to start her on low molecular weight heparin if she score high for VTE.
Okay.
And yes.
Delivery wise.
Yeah, on delivery wise, she should be on consultant lead unit. As regard the time, it will be after maturity, after 37 weeks. We may go to up to 39 weeks without any concern. She will be for vaginal delivery, except if any obstetric causes only. She will go for a C-section. As regard the precaution during delivery, it will be if she is on IV hydrocortisone, we're gonna give high dose of corticosteroid. If she is high dose of 50 to 100 milligram every 8 hours. As regard the monitoring for the baby, it will be continuously fetal monitoring, and for the mother, it will be just measuring fluid balance during labor. Keeps the patient hydrated without volume overload as well. This we can offer her induction of labor if she went to 40 weeks without any labor pain, but we will try to progesterone is prostaglandin is okay, it's considered safe. It's according to her her bishop score, but I have some concern about prostaglandin E2. I'll double check with my consultant if it is safe to be given at this point or not.
Okay, in case of cesarean section, any precaution for this patient?
Yes, in C-section, because there is a risk of trauma for the ectopic or implanted in kidney 1 to 2%. It will be midline skin incision. It will be under consultant in consultancy care in presence of consultant and the transplant team as well. We sometimes when we offer her a scan before the section just to locate where is the renal graft, it will be like a consultant. It will be midline skin incision. Then the uterus in itself, it will be transverse lower incision. Try to avoid any problem. And during a C-section as well, we will give her high dose of steroids.
Okay, postnatal.
Postnatal, we will try to actively manage the third stage of labor to try to avoid ergometry because it's not suitable with high blood pressure or kidney patients. As regard the breastfeeding, we will encourage breastfeeding, and we will ask the baby doctor to review the baby. We'll assess her for VTE assessment to give her thrombophlaxis for around 6 weeks after delivery. We'll provide her with proper kind of contraception to avoid unplanned pregnancy later, and we'll arrange a follow-up with a nephrology team as well. For the baby, if she's taking specific some drugs which is decrease the immunity, sometimes we offer to decrease avoid live attenuated vaccines for the baby. As regard to breastfeeding, for if she's taking sometimes there is some side effects from some medications. We will try to liaise with baby doctor about these issues.
Okay, thank you, Dr. Ahmed.
Okay, thank you. Thank you.
Brilliant, Ahmed. Thank you very much. You did the task in very, very nice. Okay, excellent. To be honest, everything is you tackle the point, all the point regarding all the question. You answer all the question in very good way. Your applied knowledge about the transplant organ and the management of the pregnancy transplanted kidney is very good. So I didn't think you missed any point. Very, very small point, like to warn a patient to monitor the symptom and sign of acute rejection of the kidney. Okay, so if she feel fever, line pain, anuria, or any deterioration of her kidney function, to check or to come immediately to the hospital or to refer herself back to the specialist doctor. Okay, and you talk about the steroid. If she is on IV hydrocortisone, she should be given hydrocortisone. I think you mentioned the dose in not correct way, but if it in prednisolone tablet, even if it tablet not necessary to be on IV, even if it and prednisolone tablet 7.5 for 2 weeks, she should receive the stress dose of hydrocortisone, which will be 100 milligram every 6 hours till the delivery. This is a very small point, but otherwise your answer, your performance is excellent in all the question from the first one to the last one. So the first question, what is the important information you wanted to know about the patient? You go systematic and organized, you ask about everything. The most important is the history of present illness. We have a template already in our mind, so even if the structured discussion, we should have a template in our mind, like in the simulated patient task. So how the history should be started, it should be started by the history present illness, then go to obstetric if we are going to talk about obstetric patient, then gynae, the medical, surgical, and social, drug, family. Okay, and this should be the organized. So you should have a template in your mind, like Ahmed did. Okay, start usually by the history present illness. So it can't be in the exam to start by, I will say, I ask about her, for example, smoking, or for example, her social life, the support at home. You cannot start by this way. You can start to ask about the kidney disease. Okay, what is the main problem? The kidney disease, which is the history of the present illness or analysis of the complaint. You may say, Ahmad, also I will review the notes of the patient. So collecting the information can be done from the patient history and also from reviewing the patient's notes. So history present illness, you ask in details about everything. Thank you very much. You ask about the kidney disease, okay, and the renal transplant, any complication have happened after the transplant. When was the last consultation with her kidney doctor? Did she talk about her plan with the specialist doctor? She mentioned that she talked about her intention to be pregnant with her specialist doctor and what he advised her. He may be advised her not to become pregnant. Okay, so we have to know that. So did she talk about that with her specialist doctor and any recommendation for him? Okay, and what is the blood test? What is the last kidney function test and how she feel right now? Then go to the gynae history, ask about the period. Okay, she may be pregnant now, so I want to ask about the period and last one. And we should ask about the contraception. She may not use contraception and we wanted to postpone the pregnancy now. We wanted to give her another one. So like Ahmed mentioned, what is the contraception she used. Okay, any medical background, it may be the original cause or it may be the problem of the kidney disease like hypertension or diabetes. Whether she had any surgeries before, it may affect our mood after that of the delivery. What the drug she used right now for this, what is the drug, and whether she started to use folic acid already because she is planning to get pregnant, and she has any allergies at all. Okay, then the social history and the family history, if relevant. Okay, so the examiner will give you a piece of paper by this like that. Okay, you may read this information in by silent way, in silence. Okay, if you don't want to read it by loud voice, or you can read it in front of the examiner, but don't read it as it written for you like that. Don't read it like it is written. Try to make a summary for that. Try to make a summary for the notes for the examiner, or you can read in your silent and don't make loud voice. So the examiner will ask you after that what will be the management plan for you for this patient in the preconception and the antenatal and the postnatal period. In the preconception period, if any patient with medical disorder come to talk with you about her plan for pregnancy, or about her intention for pregnancy, you have to talk about two things. Two things is very important in the preconception period. To talk about the drugs, to review the drugs, and to talk with her about the effect of the pregnancy and on the disease and the effect of the disease on pregnancy. I think Ahmed missed this point. To talk with the patient because she may not know about the effect of the pregnancy on the renal transplant and the effect of the renal transplant and the kidney disease on the pregnancy. You have to talk about this as well. So regarding to review the medication before pregnancy, Ahmed did it in a very nice way. This patient she already on mycophenolate, so she should stop this mycophenolate at least 3 months to give time for wash up, and she should use another regime for that, like azathioprine. she should continue for the contraception till the time of the wash up of the mycophenolate and stabilize on the new regime, and should you continue the folic acid for at least 3 months before conception. This is regarding to the mycophenolate. Go to the lisinopril. As Ahmed mentioned, also she has to change this to a baby-friendly drug. You may mention what should be the baby-friendly drug. It may be labetalol or alpha-methyl-dopa. The tacrolimus also need to be adjusted, or the dose need to be monitored every month during pregnancy, because as you know, the level of the tacrolimus can be decreased during pregnancy. Then go to talk about the effect of the disease on pregnancy and the effect of the pregnancy on the disease. How could the renal transplant affect the pregnancy? Yes, her baby may be grow smaller than expected preterm. You can mention preterm because we are in sexual discussion. Okay, no problem to use jargon or medical terms. So the patient may have a preterm delivery, may have a small for gestation age, stillbirth, congenital anomaly, and the mother herself may have preeclampsia and gestational diabetes, and she is at increased risk to have cesarean section. Regarding to the effect of the pregnancy on the renal graft, they may happen deterioration of the kidney function and acute rejection as well, which is in 2% of the patient. So the care of the patient, the antenatal care, how could be done? The antenatal care, Ahmad mentioned it in a very nice way, very, very, very good. He didn't miss any point. Multidisciplinary team, including that and that and that. Consultant lead unit, okay, she will be offered the routine booking test as any other woman. Besides that, we will add a renal function test and the 24-hour proteinuria and MSU. She will be offered the dating scan, the anomaly scan, growth scan. This patient should be offered the growth scan. She will be offered low molecular weight heparin, especially if she has significant proteinuria, like Ahmad mentioned. She will need tacrolimus to be monitored every month because its level may be affected by the pregnancy. Her blood pressure should be monitored and should be kept within the normal range, and she will need the multidisciplinary team to adjust the mood and decide the mode of delivery at around 30 to 34 weeks. So how will be the delivery of this patient? The vaginal delivery is recommended for this patient. The examiner may ask you about that. Okay, whether you recommend for his cesarean section? Cesarean section only if obstetric indicated. Okay, so vaginal delivery is recommended for this patient, but during the vaginal delivery, we have applied for her continuous monitoring. If she is in pregnancy alone, she should receive the stress dose of the hydrocortisone, avoid ergometrin in case of hypertension, and the prostaglandin and oxytocin, like Ahmad mentioned, no problem for this at all. In case of C-section, okay, so the multidisciplinary team should be included because they know the site of the graft. She can be offered ultrasound before the section. We will do midline skin incision and transverse uterine incision. There is risk of uterine trauma about 1 to 2%. Postpartum, the baby doctor should examine the baby. Okay, some baby may have thymic hypoplasia from the steroid. We will keep the blood pressure within normal range. Should be referred back to the transplanted team. She can refer back. She can come back to the enalapril if it's necessary for her to come for ACE inhibitor. So enalapril is safe for breastfeeding. Contraception, like progesterone only contraception, will be safe for this one, and monitor the symptom and sign of acute rejection like anuria, fever, and Lyme pain. Sometimes if the patient receives biologics, sometimes of the biologics, the baby shouldn't use life attenuated vaccine for at least 6 months. Thank you, Ahmed.
Thank you.
Thank you. Dr. Aisha, are you with us?
Oh, yes, sir.
Okay, good. I will adjust 2 minutes for you.
Okay.
Okay. Okay, 2 minutes finished. I will adjust 10 minutes now.
Oh.
Start.
Hello, I'm Dr. Aish, one of the doctors in the gynae ward today. Is this Mrs. Sarah Adam?
Yes,
How may I address you?
Sarah is fine.
Okay, Sarah. I can see I have gathered from the notes that you underwent a keyhole surgery, and for that, I'm here to debrief you about the surgery. But before that, is it okay if I can ask you a few questions at first to know more about you?
Okay, sure, doctor, no problem.
Thank you, Sarah, for that. Sarah, I can see that you were supposed to meet my consultant, but he is not around due to unavoidable circumstances. So, is it okay if I can proceed the consultation on his behalf?
Yes, no problem, doctor.
Thank you, Sarah. Thank you, Sarah, for that. So, Sarah, may I know how's your recovery after the surgery?
I am fine, doctor. I am fine.
Sarah, are you in pain? Sarah, are you having any pain?
No pain, only mild soreness, but I can manage that.
Okay. And Sarah, have you started to eat and drink well after the surgery?
Yes,
Mm-hmm. And are you able to walk in the ward around?
yes,
Any pain or swelling in your leg?
no,
Mm-hmm. Any chest pain?
no.
Mm-hmm. And Sarah, and may I know, can you tell me why this procedure was basically done for you?
Yes, I came in the A&E with severe vomiting and pain, and they examined me and told me that I have a large cyst which is twisted around itself, and I have to go to the theater immediately. But they don't tell me, doctor, that they will remove my ovary. I don't know why they remove my ovary. Oh my
I'm
God.
so s-
Oh my.
I know, Sarah, it must be difficult for you. Surely I will be addressing that for you. But just few more quick questions to know more about you. Sarah, have
Okay.
you ever been pregnant before?
No,
Mm-hmm. Okay. And can you tell me when was your last period?
since 2 weeks.
Mm-hmm. Okay. And are they regular?
Yeah,
And how about your cervical screening? Is it normal updated?
yeah,
Mm-hmm. And are you on any form of contraception, Sarah?
yes, microgenol.
Okay. And otherwise, Sarah, have you ever, otherwise you are fit and well?
Yes,
Any surgeries in the past?
no,
Mm-hmm. Any drug allergies?
no.
Mm-hmm. And Sarah, and may I know how's the support at home?
My partner is very lovely man.
Good to hear that. And how and other okay. And Sarah, any okay? Thank you, Sarah, for may I know, do you have any drug allergies?
No,
Thank you, Sarah, for sharing all this information with me. Anything else you would like to add?
no.
Mm-hmm. So, Sarah, is it okay if I can review your notes and have a look and your observations? Is that okay for you?
Yes.
Okay. So, Sarah, as I would be discussing with you regarding the procedure, do you want me to call someone to be there with you before I discuss about the operation you
No,
had?
doc. No, no. I can manage.
Okay, Sarah. So, Sarah, let me explain you what happened during the surgery when you arrived to the hospital, and as you mentioned that you were having severe pain. So the team of doctors, they decided to take you to the theater, and this was a keyhole surgery as planned for you. Sarah, when my consultant was there in the surgery, he opened up your tummy by giving a small cut on your tummy. Then what we found that the ovary was twisted on itself. If you look at this drawing with me, that the ovary was twisted on itself, and because of that twisted ovary, the ovary the ovary was enlarged in size. It was twisted 2 to 3 times on itself. Because of that, the ovary was not receiving there was cut off blood supply to the ovary, and it has turned black in color. So the team
Oh,
of doctors I'm so sorry, Sarah. So because of that, Sarah, what happened? The team of doctors, they tried to save your ovary, but however, it was not safe for you to save it was not safe decision in your case to save the ovary, because if it was left because this dead piece of ovary, if it was left inside, it can cause some infection, and even it can be life threatening for you. So for in the best interest of your Sarah, the team of doctors, I'm sorry to tell you that they decided to remove your right ovary and the tube as well.
okay, doctor. So why they didn't tell me that before the surgery?
Sarah, actually, your concern is quite valid, Sarah. Let me explain you that during the surgery, there is a possibility that it could happen. However, I would look into the matter that why it was not discussed with you before. So for that, I have already initiated an incident report to see why and where things went wrong. And once the results will be available, I will be honest and open to discuss them with you. However, Sarah, the quite reassuring thing on the other hand is that your left ovary is and left tube and the left ovary is fine. So whenever you plan to have a baby in the future, you will be able to get pregnant.
Okay,
Sarah,
so
please.
is it cancer, doctor?
Sarah, let me assure, at the moment, Sarah, we are exactly not sure that what exactly it is. However, the sample of tissue has been sent to to the exam for the examination under the microscope, and once the results will be available, we will be honest and open to discuss them with you.
Okay, so when
Mhm.
can I go home, doctor? And can I drive to till my home?
Sarah, let me explain you that at the moment we are keeping you under observation, as to make sure that everything is fine, you are able to eat and drink well. Sarah, may I know, are you able to tolerate the pain?
Yes,
And have you started taking the tablet forms of the medication?
yes.
So, Sarah, once I will have a review with my consultant that if everything is fine, we can discharge you back home, and we'll be arranging the follow-up appointment for you once the test results will come back. And the recovery time is around 4 to 6 weeks. And once you're stable, then you'll be allowed to have your driving and and you can get back to your routine activities as well.
Okay, so doctor, why I have this test?
Sarah, at the moment that why you had this condition is the exact reason that why did it happen is not known. But sometimes the ovary can enlarge because of certain reasons. If the woman is having sometimes if there's any infection in the ovary that could lead to the ovary to enlarge in size. Because of that, it twisted by itself. Because of that, it might be one of the reasons. However, once the results will come back, we'll be in a appropriate position to answer your queries in a better way.
Okay, doctor. So when
Mhm.
should I take again the contraceptive pills?
Mm-hmm. So, as far as the contraceptive pills the contraceptive pills that you are taking, with regards to the pills, let me explain you that the pills you are taking, you can continue taking these pills once again you can continue taking it from right after the surgery, because these contains only the hormone progesterone, and which is safe in your condition to continue taking them.
Okay,
However, the contraception which contains both estrogen and progesterone hormone, they may not be safer one for you at this point of time.
okay.
Any other questions, Sarah, would you like me to address for you today?
No.
So, Sarah, for now, I will be informing my consultant about the discussion, and will be writing in your documents. And if at any time you feel that you're having any pain, just call me or one of the doctors or the nurses around you. Thank you, Sarah, for your time today.
Thank you. Thank you very much, Dr. Aisha. Well done. Excellent. You still have 1 minute and 9 seconds, but finish. You managed to finish before the time. Thank you very much. You did the task in a very nice way. Your communication with the patient is excellent. You use lay language um, in a very nice way. You give the information a small chunk so she can understanding. Your sympathy in the patient with the patient is perfect. Sure, that if this patient come in the exam, there will be a lay examiner. Okay, they used to bring something like that in the exam. So there's some debate or something wrong in the consent. The consent didn't taken well for the patient, like this patient and the patient who have hysterectomy and there was placenta accreta. So the examiner will be there in the exam to see how you will negotiate with the patient, how you will counsel the patient, whether you will put a blame and you will undermine your colleague, and what you will do. But the best thing is that they didn't do that, and you managed to talk with the patient and to try to make the patient calm. And the start she was angry and she was very disappointed about the surgery. Okay, so you're the way of the communication, who is the way that they decide what the patient will do. If you go against the patient and you say you signed the consent already, and you know that, okay, the patient may become angry, and maybe you may lost all the situation in the exam, but your communication is perfect. Only I wanted to, before I forget, the macrogenome, it is a combined type of contraception. So don't forget
Oh,
this point. Macrogenome is a combined, so it should stop or to wait
yes.
for this type of the contraception for 2 weeks, or at least
Hmm.
the next menses. Okay, if you are not sure,
Hmm.
if she mentioned any type of contraception and you don't know in the exam, tell her that you did it in a very nice way. You said the progesterone only is safe for you, but the combined type. So you may say, I will check whether it is a combined type or it is a progesterone only type. So if it's a progesterone only type, you can take it. If it's the combined, you should wait for at least 2 weeks. For example, the role player may say a new drugs or a new contraception, and you don't know about that. So they tell her that I will check for that. I will check which type is this
Hmm.
contraception you are taking, whether it's a combined type, or the progesterone only type. Okay, you may say, I will check with my consultant about that if you don't know about this at all. Okay,
Hmm.
that
Yes.
the microgenome before I forget this point. But
Yeah,
mm,
thank you, sir.
all that task, you did it in a very nice way. I want from you only for the history present illness. If you ask about the cyst itself, you ask about the event, but if you ask about the cyst itself, did she know about it before? She has any scan before? She feel that she lost weight, she lost appetite, any pressure symptoms like problem in opening bowel, problem in peeing, like that. So this to assess the cyst, whether she has any problem during sexual intercourse. She may also have an endometriosis or endometrioma, which may be the cause of this cyst. So, and this to check for the assist the cause of the cyst, and whether she know about the cyst before or no. Okay, so to make the history full, you have also to ask about the cyst itself. What else I wanted to? Yes, family history. You forget to mention to ask about the family history, whether she has any family history of cancer in the ovary, in the breast. Okay, also to assess her risk of this patient. She has a large cyst and removed. Okay, so if you ask about this point also, it will be amazing. Okay,
Hmm.
so this is only the few things, but otherwise your performance is excellent, patient safety is excellent, communication with the patient perfect, sympathy with the patient is perfect. The patient try to push you from the start to talk. You are clever because the patient try to push you to talk about the event, to talk about, but because I think you put a template for yourself, you make an agenda for yourself, you wanted to finish the history, and after that you wanted to talk about what happened in details. Okay, so you have two ways: either to go direct to explain for the patient the surgery and what happened, and after that you go to take the history, or you do like Dr. Aisha did. You take the history first, try to postpone the counseling, try to postpone the drama till the end of the history, because you may forget to take the history after counseling the patient start to cry, the patient started to be anxious, start to be angry, like that. So you may forget to take history. So please be clever, like Dr. Aisha. Dr. Aisha, try to postpone that, try to counsel the patient, try to express the concern. Yes, I understand how you are, how anxious you are, or how upset you are, but in a moment I will come to explain what happened for you. But before, it's the first time for me to see you today. Can I ask you some question to know more about you? Okay, so try to put a template for yourself. Try to move the scenario as you like, not as the role player like. Okay, because in the exam, because of the stress of the exam, all of us have gone through this. The stress of the exam, you may forget some point, and you will forget some point sure in the exam. But if it's small point, no problem. But if it is large point, it will be a very big problem. So I will counsel the patient after I finish the history. So if the patient try to push me, I will try to defer that till the end of the history taking. Okay, Sarah, I understand your concern. I can see how upset you are. But because it's the first time for me to see, can I ask you to see you today? Can I ask you some question to know more about you? At the end, I will talk with you about what happened and what is the suggested plan for you. Is it okay? Sure, she will say okay. Okay, so if you ask about the background of the surgery from the start, it will be also perfect and perfect. So do you know about what happened in the surgery? She will tell you that I know that she removed my ovary and okay, so you know that the patient already know had a background. The patient know that she removed her ovary. Okay, sometimes the patient may know don't know, so you will come as because it may come as a breaking bad news. For example, if you remove the history, the uterus, for example, and you come to talk to tell her that we removed your uterus, your womb, so it should be done as a breaking bad news. So you should know whether the patient know or the patient don't know. So if the patient come from the out from the surgery and it's not clear from you in the instruction outside whether the patient know or no or don't know, try to check the background. Do you know anything about the surgery? Do you know anyone to come to talk with you about the surgery? Okay, if it's not clear outside, you are the first one. You will talk with the patient, or you are the first one to tell the patient that she removed her uterus and. Okay, if it's not clear for you, if it's clear, if the instruction is clear, okay, that's okay. So ask about the history of present illness. The good thing that you ask open question. Very good to start the history taken by good question. Okay, so could you tell me what happened? Very perfect and very nice question. I like this question too much. Could you tell me what happened? She will tell you everything. If she forget to mention anything, try to address this point or to ask about this point. After talking about, she will tell you that I have pain and vomiting and. Okay, so you may ask about the cyst itself. Did you know before about this test? Did you have any scan before about this test? Did you feel that you lost weight in the last couple of months? Did you feel loss of appetite in the last couple of months? Any problem in opening a bowel? Any problem in peeing? She will say no, everything is fine. So go to the recovery. So after taking the histopathology, let's go to the recovery. Okay, did you start to move around? Did you start to eat and drink? Did you manage the pain by simple painkiller or by the tablet form? Okay, this is to check about around it. Did you open your bowel? This is to ask about the recovery. Then go to the remaining history. Ask about the gynae history, the sexual history to assess the risk factor and what is the maybe the possible cause of this cyst. You mentioned that she is on microgenome contraceptive, combined oral contraceptive. Okay, she may ask you, can I start it again? Okay, the combined can be started 2 weeks at least after the surgery. Okay, then you don't, as we mentioned, don't forget to ask about the family history to assess the risk factor also for any cancer in the family. Then come to explain for her. Dr. Aisha examine or counsel the patient about the surgery in a very nice way. She try to deliver to the patient that there was a very big thing, and we save your life. So the patient will thank you instead of make a complaint. She will thank you. So there was a very big thing, and your life was in danger. And because we are a good people with you, we remove your ovary. So please thank you. You should thank me about that. So the patient now will be very polite and she will be very calm after this counseling. So during the surgery, the cyst, there was a very large cyst and this filled with, sorry, and filled fluid sac inside the ovary, and um, it make your right ovary and tube twisted around itself, and so the blood, excuse me, just a second. Okay, so because of this large cyst in the right ovary and the right tube was twisted around itself and the blood supply was cut off, so we have to remove this to save your life, because if we leave it, it will lead to an infection and the spread of toxin in your body, and this will affect your life. Is it clear? Okay, so there was a very big thing, and we save your life for this thing. If we lifted the ovary, your life will be in danger. So he may say, okay, doctor, so why no one tell me that before the surgery? It should, ideally, it should be in the consent. Any woman will go for surgery in the ovary, like a cyst or anything. She should be consented for a possible oophorectomy and salpingectomy. But sometimes it may happen in the emergency. So please don't put blame or don't undermine your colleague. So, but we have to assess the patient safety, and we have not to ignore this concern of the patient. Yes, what is her name? The patient name, what is her name? Her name is Sarah, yes. So Sarah, yes, I totally understand your concern, and ideally it should be done before the surgery. It should be involved in the consent, but it may be because of the emergency situation, and or of my colleague was dying in a rush to save your life. But I wanted to assure you that there will be an incident report will be written, and there will be a group of expert doctor collect the information and will give you clear explanation of what happened. Okay, so this would trigger an incident report. She will ask you about the effect of this on the removal of the effect of the removal of the ovary on the pregnancy. Yes, sure. It will not affect her ability of pregnancy. She can be pregnant whenever she think about the pregnancy. It is a sinister cells. It is a cancer. We don't know till now, Sarah. Until now, don't know, but it is very unlikely in your age group, and also she doesn't have any risk factor in her history. So most of the cysts will be benign, but the cyst will be examined in the lab, and they will give you after the result, we will give you appointment to discuss the result with each other. Okay, so when can I go home? She can go home once she can eat and drink. She can control the pain with simple painkillers. Okay, but regarding to the drive, she can drive only if the pain is settled and the pain can be managed by the simple painkiller. Any patient would go home after surgery. You have to warn her if she have a severe pain in her tummy. If she feel very unwell, she should come back. So give her the warning sign. Thank you, Aisha.
Thank you so much for the opportunity, sir.
Yes, Dr. B, can you mute yourself, please? Yes, that's fine. Okay. Dr. John, are you with us? John. Dr. John, are you with us? Okay. Dr. Tanya, are you with us? Tanya?
Yes, sir.
Hello?
Hello. Yes, I can hear you.
Yes. Yeah.
Okay, good, good, good. Okay, just 2 minutes.
This is my case, sir.
Yeah. Okay, 2 minutes started. Okay, I will adjust now 10 minutes. Start, Tanya, please.
Okay. Should I start?
Yeah.
Okay. Hello, I'm Dr. Tanya, one of the doctor in the clinic today. May I confirm your name and age, please?
Yes, I'm Lucy Brown, 67 years. Hello?
How can I address you?
Yes, Lucy is fine.
Hello, how can I address you?
Lucy is fine.
Okay. Lucy, I can see that we are supposed to discuss about your report today. Okay.
Ye-
Lucy, I can see that we are supposed to talk about your report, but before going to discuss about that, I would like to ask you a couple of questions to know more about you so that we can make a shared care plan. Is that okay, Lucy?
Okay, that's fine.
Okay. Lucy, may I know about your concern and expectation from today's consultation?
Yes, doctor, I bothered with this itching for a long time. I tried everything. They gave me emollient and corticosteroid. I have used this as well, and nothing is helpful at all. Finally, the GP referred me to the dermatologist, and they take a biopsy from me, and I'm here today to know the result of that.
Okay. So, Lucy, would you please tell me details about your complaints?
Yeah, I have this itching in down area. Okay, and it was since a couple of months I received some treatment and nothing is I touch this itching at all.
Okay. Any pain?
No, I don't have pain.
Okay.
I think there is a problem in the
Any skin breakout?
no.
Lucy, am I audible, Lucy?
Yes,
Hello?
yes, hello.
Am I audible? Now
Yes,
clear?
yes, now. Okay,
Hello? Okay.
hello.
Okay. So Lucy, can you please tell me, do you have any similar lesion around your vagina,
No,
back passes?
what?
Okay. What about your waterworks?
It is normal.
Okay. Bowel habit?
Normal.
Okay. Is this affect your quality of life, Lucy?
Yes, doctor. Yeah. I cannot tolerate this itching uh, anymore. I bothered by this couple of months, and I need a definitive treatment for that.
Okay. Lucy, for how long you are in menopause? I mean, gone through your changes?
Yes, I am menopause since 10 years.
Okay. Uh, what about your last smear report?
Yes, it was normal.
Okay. And are you up to date with that?
Yeah,
Okay. And are you medically fit and well?
yes,
Any allergy?
no,
Any asthma?
no,
Any surgery, Lucy?
no,
Okay. Do you have any skin disease that run in your family?
no,
Okay. Sorry for asking your social habit. Do you smoke?
no,
Alcohol?
no,
Any recreational drugs?
no.
What do you do for your living?
I'm housewife now.
Okay. What about your support at home?
Yes, my partner is very supportive.
Okay. May I know, are you aware of your weight-height ratio?
Yes, it's 28.
28. Do you feel down or depressed for the last few weeks or month?
No.
Okay. So Lucy, I have checked your if you allow me, I can see that already your examination done, and I can see that there is some white area in your down below. So Lucy, I have checked your name and NHS number, and this result belongs to you, and it is showing that the cell is changes. That means the abnormal change cells that line the surface of your skin that cover um, mm, the cover of the vulva. Are you getting me, Lucy?
Yes, doctor. What are these abnormal cells?
Actually, we call it the high grade lesion. That means this is not cancer, but the cells that cover the surface layer of the skin of the vulva undergo some changes, and these cells has a high chance to develop or turn into cancer.
Oh my
I mean,
God.
clear so far?
Why I have this, doctor?
Actually, Lucy, you have a condition previously. We call it like an sclerosis.
Okay.
And this skin condition that occurred due to some faulty faulty immune system of own body,
Okay.
and that condition leads to abnormal changes of the cells of the vulva, and this is high grade lesion.
Okay. Okay. So what will be my
Um,
treatment, doctor?
Actually, Lucy, if we have couple of options to do that, and
Mhm.
if it is not treated, then 9 to 18 out of 100 women may develop cancer if it is left untreated. Okay.
Okay.
So first of all, we will ask you to change your lifestyle, and you have to use the you avoid the panty liners and use cotton clothing. And the option for you, this high grade lesion will be excised. That means we call it wide local excision. With a healthy margin, we have to remove that and will be sent for the for the lab for test. This is the treatment of choice. Am I
Okay.
clear,
Yes, you are
Lucy?
clear, doctor.
And
But there
and
is no other method other than this surgery. I don't like surgery.
yes, yes, other some option is that we can give you cream named imiquimod cream that enhance your immune system, and another option is some laser can be used that
Mhm.
will destroy the abnormal tissue, but the problem is that associated hair loss and change in the skin color can be happened. Okay.
Okay. Okay.
And another one is for photodynamic therapy. That means the heat will be applied
Mhm.
on that abnormal tissue. Okay.
Okay. Okay. I want this cream, doctor. Yeah.
uh, yeah. And if another option we can go, that is we call radical surgery actually, that
Okay.
is vulvectomy with reconstruction. Nowadays, due to morbidity, we avoid this.
Mm.
Okay.
Okay. Okay.
And another one is to for soothing. We use some cream and ointment. Some steroid cream is used to ease from this inflammation and itching, and also some anesthetic ointment is used to relieve some pain and itching. And also you have to avoid the soap and bubble bath. Okay,
Okay. That's
Lucy.
okay.
And you have to use the blunt moisturizer.
Okay. Time finish. Okay.
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 So I will give you the follow-up appointment in the vulval clinic, and
Mhm.
you have to take follow-up. And another one is you have to self-examination yourself to
Mhm.
see any color change, any ulcer, any discharge of the affected area. You have to careful about that. Okay.
Okay. Thank you.
Okay, so I'm giving you the detailed information and connect you to the support group and giving you the another appointment. Okay, thank you
Okay.
for your time.
Thank you. Thank you very much. Thank you, Dr. Tanya. Well done. Thank you very much. You did the task in a very nice way, but take care of the time management. Okay, as you mentioned before, anything you will mention after the time, you will not take any credit for that. So take care. You have to finish within the 10 minutes. Okay, so try to practice it again and again. Regarding to the communication with the patient, communication with the patient is perfect. You use a lay language, you explain for the patient in a very nice way, short sentence, check understanding. But if you are in a face-to-face exam, you have to draw, okay, because drawing will increase your mark in communication. Regarding you applied knowledge about the like sclerosis and the VIN, okay, it perfect. Applied knowledge is perfect, but I'm afraid about the information gathering and the patient safety. You missed some point in that. So, for example, in the information gathering, the histopresent illness, you have to ask in details about that, about this illness, about this VIN, to check whether it changed to being sinister or no, like loss of weight, loss of appetite, whether she has any discharge from blue. Sexual history, you didn't cover the sexual history at all, so you have to ask about the sexual history and whether it is affected by this problem or no. And this patient already, it was in my exam, and if the sexual life was affected by this problem, and you have to counsel her about that, and you have to offer support for her and psychosexual counselor and show some sympathy regarding this issue. Okay, so please also ask about the sexual history. Family history, you didn't ask about the family history, otherwise the family history is important, whether she has any family history of cancer in the vulva, cancer in the cervix. Family history in case of cancer is very important. There's no need to ask about recreational drug in a 67 what is it, 67 years old. Okay, I think it is not it is you can't justify to ask about the recreational drug for a patient who is old age to ask her whether she is using street drugs or recreational drug. Try not to ask this question because it may be offending to this patient. Okay, so this is regarding to the information gathering, but other than the information gathering is very good. You ask about the cervical smear, it was up to date and normal. The medical history, okay, it was very good information gathering. So come to explain for her the VIN. You explain for her the VIN and on the top of the courses in a nice way. But if you draw, as I mentioned before, if you draw for her, okay, it will be more and more perfect. Okay, so let's go to the suggested mode of answer of this task. Okay, so you will introduce yourself for this patient as you did. Okay, hello, I'm Dr. Tanya, one of the senior doctor in the clinic. Today, may I confirm your name and the date of birth or NHS number? She will say, I'm Lucy 1234. Okay, so check the purpose of the meeting and put agenda. Okay, you have to put agenda for yourself, Dr. Tanya, also. Okay, so after checking the concern of the meeting today, okay, so before we discuss the best management plan for you, can I ask you some questions to know more about you, and they may examine you the business of Chevron if you don't mind? Okay, at the end we will talk about the suggested plan, and we can reach to agreed plan to each other, and I will give you some patient information leaflet to read. Is it okay? Okay, so you have to put an agenda for yourself before going to the history. Then go to the history. We should normally or usually we start by the histopresent illness. So ask about this lesion. Okay, ask about this itching. Could you tell me more about that? She will mention most of the point. If she forget to mention any point, you have to ask is specifically or closed. So any pain from down, any bleeding, any discharge, did you lose weight, did you lose appetite, any problem in opening a bowel due to spread of cancer or something, any problem in water work due to spread also. Have you tried anything for that? To check whether she tried anything for this problem or no. Then go to the gynecological history. The most important in the gynae here is the sexual history and the cervical smear. So are you sexually active? I'm sorry for my tweeting question. Sign post for yourself. So are you sexually active? She will say yes. Okay. Do you have any problem during sexual intercourse? She will say yes, doctor. I also have some burning sensation, or I have pain during this sexual intercourse, and it made me make my husband disappointed. You have to show sympathy for that. I am so sorry for that. And how you cope with that? How you partner cope with that? She will say he is understanding and okay, if you don't mind, we can refer you to the psychosexual counselor. Okay, who can offer you some ways and to try to control about this pain. Is it okay? She will say, okay, doctor. Then go ask about the cervical smear. Okay, and go through the remaining history, which is the most important one, is the family history, to check whether she has a family history of cancer or not. You may offer to examine the patient. Okay, in the Osler, I think in the Osler they said no need to examine the patient in the Osler, but in the face-to-face you may offer examining on the patient. The usual examination of the patient in the form of general and abdominal and the local examination. Then come to explain for her the result. Before explaining any result in the world, any patient come with any test, any patient come with any scan, you have to confirm the identity. You have to confirm the identity first. So is it Sarah Joyce? Is it Lucy Brown? Is it any name? Okay, NHS number 1234. She will say yes. Okay, or you may say after confirming your name and the date of birth or the NHS number, Okay, we can come now to explain the test result for you. Is it okay? Okay, so you have to confirm the identity, okay, and this will be considered as patient safety. So, Lucy, the test shows that you have abnormal cells in the skin of your vulva. The vulva is the outer lip of your vagina, and it is called VIN. It is not cancerous, but it needs to be treated because and follow up because it may develop to a cancer in about 9 in 100. And key so far, she will say, yes, Dr. From where I have this VIN and why I have this VIN, Lucy. Basically, from your history and the examination, you have a condition called lichen sclerosis, which is a chronic inflammatory condition happening in the skin of the vulva. The exact name of this lichen sclerosis is unknown, but it believes that it is an autoimmune condition where the antibody form where the body form antibody to attack the cells in this area. And this lichen sclerosis badly or sorry, it is progressed to VIN. Am I clear so far? I am so sorry to tell you that. She said, yes, doctor, you are clear. So come to explain for you now explain for her the VIN on the top of lichen sclerosis. You have to explain for her what it means by stage 3. Stage 3. Okay. There are two ways to explain for her stage 3. The simple one is the second one. You may draw some cells on the right side, normal cells. Here is the normal cells. And try to explain to try to draw some any cells in the right side, and they come to the left side. And here is the sinister cells. In between, it is abnormal cells. So in the right side, you will draw some cells. It is abnormal cells, and in the left side, you will draw a sinister cells. Here is the sinister cells, and in between the normal and the sinister, there is called abnormal cell. Okay, and in between this is abnormal cell, you will try to draw 3 cells, 1, 2, 3. The one who is near to the normal, it is called VIN1. The one who is near to the sinister, it is called VIN3. The one in between, it is called VIN2. This is a simple, you can do it by drawing. There is another explanation. You may say for her, it is written there in the patient information leaflet. So the skin of vulva is made of 3 layers. The outer layer, it's called the epidermis. It's about 1 millimeter in thickness. If the abnormal cells are present in the lower half, it is called VIN1. It is in the 2 halves, it's called VIN2. If it involves the whole thickness of the epidermis, it is called VIN3. Okay, you are in VIN3. So what is the treatment option for this patient? Her treatment should be under a group of doctor, multidisciplinary team, which include the gynecologist, the oncologist, the pathologist, psychosexual counselor, specialist nurse. She need to be referred to the colposcopic clinic to rule out cancer cervix. And the treatment option, it will be one of three. The first one, it will be the surgery with safety margin 1 centimeters. We will remove the affected area under anesthesia, not to feel any pain. There are the pros of this surgery is it is a curative, and we can take the biopsy to be examined in the lab for any cancer cells because there is an undermining cancer about 2100. The disadvantage is the pain, infection, and scarring and distortion, which may need cosmetic surgery. The second option, Lucy, it is the cream. This cream can use your immune system to attack the area of the VIN. So the pros of this, it is no surgery at all, can be applied by yourself at home, and can be used in case of cancer. But the disadvantage, it can cause some burning sensation. The last option is the laser. The laser can be only used in non-hair bearing area, but it has a high failure rate, 40%. Okay, so even if we treat the VIN, this patient should be warranted that, or should be advised that there is a risk of developing a cancer about 5 in 100. So she need a long-term follow-up. Keep an eye on the vulva. If she notice any change in the color, in the any discharge, anything, it changes in the nature of this vulva, she should come back because there is risk to develop a cancer about 5 in 100. At the end, give her some patient information leaflet and contact number. Okay, take care of this patient. This one, when it come in the exam, it can come in 3 paper, not only in 1 paper, 3 paper. 1 paper by this history, and one paper by the examination, and last paper by the histopathology report. Okay, I know some may forget to read the histopathology report. So there will be 3 papers on the wall, 1 and 1 and 1. So please keep reading all the paper outside. If you go to the face-to-face exam, the paper will be outside of the room, outside the cubicle. So please be sure that you read all the paper outside before you going enter to the cubicle or to the room. If you didn't manage to finish everything, you can ask the role player or the examiner to complete finishing reading. Okay, it is your time, no problem at all. Okay, so you can ask her after introducing yourself, okay, Lucy, because I didn't manage to finish, can I take 1 or 2 minutes more to finish reading the paper, not to miss any important information? She will say, no problem, doctor. Okay, that's your time. So please keep reading all the paper outside. Mhm. Okay, so coming else. Okay, Dr. Fatin, are you with us? Fatin? Fatin Yusuf?
Yes, I'm here.
Okay, good. Good. Allow just 2 minutes. Okay, 2 minutes started. Okay, and I just now 10 minutes.
Okay. Hello. This is Dr. Fatin, one of the doctors in the world today. Is this Sarah Adam?
Are you the one who did the surgery for me?
Sorry, Sarah. I'm not one of the registrar, my consultant who did the operation for you yesterday. He's supposed to come to debrief you about today about the surgery, but he is not here. Um, is it okay to continue consultation with you?
Okay, no problem.
Yeah. So I can see that you are worried. May I ask you why?
Doctor, what about all of this tube? I have a tube in my nose, I have tube here in down in the water passage, I have tube in my tummy. What all of this tube?
Yeah, I'm really sorry that you are not happy with your care and with this tube. I would like to address your concern soon, but if you just give me a chance to ask you a few questions, and then we can discuss your situation in better way. How's this
Okay,
sound to you?
okay, no problem.
Yeah, so may I ask you how are you today? Have you started eating or drinking any food?
Yes, I managed to eat something and drink some fluid.
Mm-hmm. And have you got a chance to see your baby?
No, I want to ask about my baby as well. How is my baby, doctor?
Yeah, so actually, I would like to review your notes, maybe your baby in the NICU, and if you would like, we can arrange any video calls for you to see your baby, and
Okay.
also baby doctor can call you and give you a brief about your baby situation.
Okay.
Okay, so Sarah, I understand that this was your third cesarean section, isn't it?
Yes.
So, may you tell me about your follow-up during the pregnancy? What was your follow-up?
Yes, I follow up
Um,
in the hospital here with the consultant, and they told me that I have placenta previa, and
mhm,
they arranged yesterday for my C-section.
mhm, mhm. Yeah. So, did you have any discussion about your cesarean section before going for the operation?
Yes, yes, they told me. Yeah, they told me everything. Yeah, I'm risk of blood transfusion and I'm risk of injury. Yes, they told me.
Okay. Have you been aware that your placenta was low-lying? We
Yes, I
call it
know that.
placenta previa.
Yeah, yeah.
Mhm. Okay. So, did you have any surgery before rather than this
No,
cesarean sections?
not at all. No,
Mhm. And any medical problem that we should be aware of about it?
no, not at all.
Mhm. Okay. Thank you for sharing this information with me, Sarah. Sarah, I can see that you are alone because you are admitted. Do you want me to call someone or wait for someone to come to join our consultation?
No, no, I can't manage anything. What happened, doctor?
Yeah. So, may I ask what do you know about your operation till now rather than these tubes?
No, I don't know anything. I don't know anything.
Mhm,
No one come to talk with
mhm,
me about that.
mhm. Okay, so Sarah, because when we open your abdomen to do C-section for your baby, as you have this placenta previa, low-lying placenta, severe bleeding started during the operation, and this is commonly can happen during placenta previa cesarean section. We tried our best to control the bleeding, but actually it was severe bleeding, and we tried all the measure to stop it, but it was non-stoppable. And we discovered at that point that your afterbirth, rather than being low-lying, it also was deeply attached to the muscle of the womb, and also it we couldn't separate the bladder, and the bladder is a bag of water. It is usually, let me draw for you, if this is your womb and this is your bag of water, it is closely to each other, and especially because you have three cesarean section before, sometimes adhesion tissue and scar tissue can be there in between to this womb and the bladder. So sometimes it can be very difficult to open the womb without causing any injury to the bladder. I'm really sorry. What happened in your C-section? Your bag of water, your bladder got injured, and we called the team, the specialist team, at that time to help us to fix this injury and suture it up. But in order to make sure that the recovery and the healing of your bladder as well, we had to insert this tube that you have it down below. So it will be there in place for 2 weeks to make sure the healing is well. After that, you will have a meeting with a doctor specialized with water bag problem to make sure the healing is proper in the proper way, so we can remove it. Am I clear so far, Sarah?
Yes, okay.
Yeah. So plus to that, because the bleeding was extreme and your brother got injured and it was really, really difficult situation, we couldn't, it can affect your life. For your best interest, we make a decision with the help of another consultant to remove your womb.
Oh my God, you remove my womb. Did you remove my womb? Oh my God.
Yeah.
Oh my God. Okay. Okay. There is no any other way to stop bleeding except removing my womb.
I'm really sorry, Sarah. There was no other way to do that. We did all the medical, give you medication, and try the mechanical way to stop the bleeding, but it was not non-stoppable. And actually, this was about to affect your life, and that's why we took this decision in behalf of you.
So why no one told me that about before the surgery that I'm a risk to have to remove my
Yes,
womb?
Sarah. Yeah, ideally we should have discussion before going for cesarean section with women who had placenta previa and have previous cesarean section about what common risk that can happen and how to avoid it. Plus to that also we can just mention the high risk or the most serious one, like risk of hysterectomy. I'm really sorry that you haven't been told about that. I need to check your note and know what was the circumstances behind that. And also I will write incident report to start investigation to know the reason behind that. And once we have the result of this investigation, we will be clear and honest and discuss it with you in another appointment.
So doctor,
So,
you didn't give
mhm.
consent for that. You can do a hysterectomy or remove the womb for any woman without taking his consent for that.
Ideally, we should take consent first, but if it is affecting your life or any patient life, sometimes we had to take such decision in patient best interest. I'm really sorry that this happened with you.
Okay, so I think I will never get pregnant anymore.
I can understand your feeling, and if I was in your place, I will have the same feeling. But as you still have your ovaries, and your ovaries is fine and normal, if you want to have any more children, you can have um, surrogacy, which means that another woman will carry your genetically identical baby from your ova and your partner semen.
Uh,
So, and mhm.
for how long I stay in the hospital, doctor?
Yeah, as your operation was really difficult and you lost a lot of blood, and we have to fix this bladder problem, and we are keeping you under observation now in what we call it high dependency unit. So once you are stable and your observation is fine, at that moment we can shift you to the normal ward. After that, when you start to move around and eat and drink in proper way, in that time we can send you home.
Okay,
So, mhm.
I want to apply complaint.
It's completely your right. We have a system in place. It calls Pulse. So I can put you in touch with this system, and you can apply your complaint. And this also, beside our incident report, will help the investigation process to carry on.
Okay, okay, doctor.
So we come again to check you, and also my consultant will come to check you again, and we will arrange the video call for you to be able to see your baby.
Okay,
Okay.
thank you.
Uh, Yeah, I will also put you in touch with support group for women who had been in during the same situation. They will be happy to help you, and also support group is really helpful, and the hospital counselor.
Okay.
Thank you for your time.
Okay. Thank you. Thank you. Thank you, Dr. Fatin. Well done. Excellent. Excellent. Very good.
Thank you,
Okay.
Dr. Ali.
Thank you. Thank you very much for you. You did it in excellent way. To be honest, your communication with the patient is amazing. Your tone of voice. Many candidates can't manage this. They can tell the information, but they cannot reach it to the level of the tone of voice, which is ideal to the patient. Okay, so your tone of voice is very good. Your way of counseling this patient and negotiating with this patient is perfect. So the communication is very good. This patient was in the start was very angry about her care, but you managed to make her calm and to finish till the end. Okay, this patient was already in the exam, already she came in the exam and she was very angry, and some candidate may think that she is angry for himself or for because of this candidate himself or herself. No, she is prompted to do that, so don't worry about that. Don't be anxious and don't be nervous in front also of the patient, because it is she is an actor. Okay, she is prompted to do that. All of the situation is acting, so don't worry and don't be nervous. Try to control your nerves and try uh, to negotiate with the patient and counsel the patient with a very sympathy. So your communication is very perfect. Your information gathering about the event, about everything is amazing. Your management plan is very good. Okay, so I didn't find any weak point, to be honest. I only the point when she in the start, when if you entered in the cubic and the patient didn't listen to you and ask you any question during the introduction, you have to stop and again you have to confirm that the patient hear your name and to check the identity of the patient again. So this patient ask you direct, are you the one who did the surgery, and she didn't listen to you and you didn't confirm the identity. So after counseling her, after responding to her question, okay, I am one of the team with my consultant. He is not around now, so I am Dr. Fatin, one of the doctor in the duty today. May I confirm your name and age, please? Or it is Sarah Adam, NH number 1234. So you have to confirm. You have to be sure that the patient listen to your name, know who are you, and to check the identity of the patient. Sometimes also you may enter into the cubic and the patient mock vomiting. Once you enter into the cubic and you say, hello, I am Dr. Fatin, one of the, and the patient keep vomiting, she didn't listen to you, and or the patient keep have a contraction or labor pain and she didn't listen to you. So you have to stop, offer support, offer painkiller, offer anti-sickness, and after that, again, introduce yourself and confirm the identity. Okay, this is the only thing. The second thing, you have to check support of at home. Okay, so this patient you need to you should ask whether she has enough support at home, her partner is supportive or no. Okay, because she will pass through difficult time. So the support at home is also important here. Other than these 2 points, your performance is excellent, excellent, excellent. Okay, so the patient was angry from the start, and the good thing is that you address the patient concern and put the patient calm, and I will in a moment will discuss this with you. But if you give me time to ask you some question, because it's the first time for or to be sure that you are in a stable condition, you are in a safe hand, so please give me time to ask you some question, and at the end I will come to explain everything with you. And this is to put agenda in yourself. If the patient is try to push you to explain the surgery, okay, you have to go and explain the surgery direct, and after that taking the history. But I usually prefer finish the history before explaining the risk of before explaining the surgery. So you check about the recovery. Okay, ask about the recovery, start to move around, start to eat and drink anything. Okay, control her pain. You may ask the pain team to come if the patient is still suffering from pain. Then ask about the obstetric history, about the pregnancy, the scans, she was ever scanned in a scan or no, okay, and in other surgical history. Support at home is very important for this patient. After that, as Dr. Fatin mentioned, she has to review the mute chart. Any patient come from major surgery like that, you have to review the mute chart of the patient to be sure that she is hemodynamically stable, vitally stable, the urine, the fluid balance. So you should show the examiner that you are safe doctor after any surgery, and will review the chart of this patient, and also I may review the surgical notes of this patient. You have two ways to explain for this patient the condition. She doesn't know. So from the start, the patient, if you ask about the background of this patient, whether she know anything, anyone come to talk with you, she doesn't know. She doesn't know anything about the surgery. So you are the first one who will tell her about the surgery. So it should be in a breaking bad new way. Okay, so try to deliver the information smoothly and in a polite way. So the way that Dr. Fatin explained for her, it is very good. She explained for her that she was in a very dangerous situation, and we are thankfully save her life. Okay, so she was in very dangerous, and her life was in the extreme, and we are thankfully save her life. Okay, so this is a very good way to deliver this information for the patient. Sarah, you know that the placenta, you have a placenta previously scars, so during the surgery, the placenta invading the wall of the scar in the uterus and going to the bladder. We try to dissect it carefully, and we did dissect it already, but there was a tear in the bladder. Okay, and we closed this perfectly by the help of the urologist, which is the specialist one in this field, and we safely deliver your baby. Okay. Then the placenta was invaded deeply to the wall of the uterus, and there was a massive bleeding. We tried to remove it, and the anesthetic doctor tried to give you some drugs to stop the bleeding, but it didn't help. So my consultant tried some maneuvers to stop the bleeding, but it was horrible. So the second consultant came, and we took the decision, the difficult decision, to remove your womb, and but this was to save your life. Okay. So she will start to cry, and she will start to be angry, and I'm so, give her time to cry for her tissue. I'm so sorry to be bearer of such news. Do you want me to leave you alone for some time? Do you want me to call someone to be with you, like that? Okay. So uh, she will ask you some question, why there was any way to keep my womb, why I have this placenta accreta, why no one told me about this before the surgery, I didn't give consent for that. A lot of questions. Can I become pregnant anymore? Can I come pregnant in the future? Okay, for how long I will stay? How is my baby? I want to apply complaint. All of this will be question, will be asked by the role player. Okay, and Dr. Fatin answer it in very, very nice way. Okay, so nothing to be added more than Dr. Fatin did, to be honest. Okay, so let's skip for this one. Okay, I will leave the the picture or the slide in front of you. If you wanted to take any screenshot or any photo, feel free to do that.
Dr. Ali, thank you for giving me this chance. Actually, I got a lot of benefit.
Thank you.
May I ask one question?
Yeah, sure.
Yeah, because this patient is already in HDU, and she is admitted, and she is a very big operation. I feel it is a little bit weird when I go and check the NHS number or check the patient details, because she is admitted. I know her bed. I know where she is. She is already on my list. So I feel it is better just to make it like I know the patient, and just making, is this Chara zones, and don't ask for any other detail to double check the patient identity. Um,
To be honest, I used to do that, even if the patient, I know the patient well, because this along a lot of mistakes can happen without checking the patient identity. A lot of things could be happen if you didn't
mm,
check the patient identity. Okay, so
mm,
to be safe, you will not lose any mark if you check the patient identity. But you will lose a big mark if you didn't do that, and it was necessary. A lot of or prescribing drugs or delivering the information for someone who is not the same one, or it is not the one who wanted to talk with him. So it will not make any difference for you to check the patient identity before starting counseling her. This is from my
Mm-hmm.
side. It is not a Quran, or this is not
Mm-hmm.
an ideal. It is my suggestion for answering this question.
I'm
Mm-hmm.
sorry, Dr. Ali, this is what to be done here.
Yeah,
It is checking, especially who checklist between the sign in and time out is in between is just 10 minutes, and you double check about the patient details
yes,
again. And
yes, you are right.
even with giving medications, you have to double check about the patient NHS number, date of birth, and name as well. Okay, I'm sorry for
Yes.
interruption.
No, thank you, Dr. Ahmed. Yes, thank you very much for your question. Yes, as Dr. Ahmed mentioned here, we do the WHO checklist 2 minutes before the sign in and time out, and you have to check the patient again. You know the patient, and your patient, you are the one who does cesarean section for her, and you are the one take consent for her, and you check the patient again. Okay, so checking the patient identity is very important.
Okay, thank you for making it clear. Another one question.
Okay.
In the recovery, as the patient is in HDU, she is not moving, and what should be the ideal question in recovery? Eat and drink, because she will not be able to pass urine or go to the toilet, and she
Why?
will not be able to walk
Why? Why
because
she will not able not to work?
mm, I'm not sure, because I think in
No,
HDU patient should be bedridden or.
no. In the HDU, it is only for close monitoring. The HDU, sometimes in the HDU, we have in the labor room HDU room. Here we have in the labor room HDU room. She has a toilet, and she can go to the toilet, and she can eat and drink only for close monitoring. It is how frequent or how often we have to monitor this patient. Every 30 minutes or every 1 hour or every 4 hours. So this is the difference between the HDU, and there should be a responsible or experienced midwife, experienced nurse should be with this patient. Okay, so the patient can move, can go to the toilet, can eat and drink, nothing. Okay, only we have close
Yeah,
monitoring for the patient.
only because of the catheter. We no need to ask about this passing urine. Yeah,
Okay,
got it. Yeah, thank you.
thank you, Fatin. Thank you very much. Okay. Okay. If you give me only 5 to 10 minutes, I will pray and come back.
This conference will now be recorded.
Okay. Dr. Khairi, are you with us? Okay. Dr. Zainab, are you with us? Zainab. Okay. John. Dr. John. Okay. Okay. Dr. Hala Al-Amin, are you with us? Dr. Hala. Okay. Dr. Sadia. Sadia, are you with us? Hello? Hello? Dr. Sadia, are you with us? Hello? Dr. Sadia, are you with us? Okay. If you cannot listen to us or you can talk, there's a problem in connection, please mute yourself. Mhm.
Hello?
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 Yes.
Can you hear me?
Yes, Dr. Sadia. We have two Dr. Sadia. Are you all the one who sent to me?
Yeah.
Okay, good.
I am Dr. Sidra. Actually, I have joined from my sister laptop. Yes,
Okay,
Adya.
okay, no problem. Welcome. Okay, can you do this task, please?
Yeah.
Okay, I
Is
will
my
just
voice?
yes, your voice is totally clear. Okay,
Okay.
just 2 minutes for you now. Start 2
Yeah.
minutes.
Should I start?
Okay, I will adjust time. I will adjust 10 minutes for you. Start.
Hello. I am Dr. Sidra, one of doctors in the emergency gynae clinic today. May I check your name and age, please?
Yes, I am Sarah John. I'm 30 years.
How would you like me to call you?
Sarah is fine.
You can call me Sidra.
Okay.
So, Sarah, I have gathered that you are here today as you are 5 weeks pregnant and now you are having a bleeding from down below. Is it right?
Yes.
Any other concerns you want to tell me?
No.
Okay. Sarah, before addressing your concerns, since we are meeting for the first time, is it okay for you if I ask you a few questions to know your condition in a more better way, and then I will discuss your condition, your ultrasound, what has been done on you?
Okay, sure.
Okay.
Yeah.
Okay. So, Sarah, can you tell me more about your pregnancy?
Yes, this is my second pregnancy. I have one vaginal delivery before, and it was straightforward. This is my second one. I'm now 5 weeks, and everything was fine till yesterday. I have some spotting. I don't have pain, but this is spotting. I don't know why this is spotting at the first time for me. I don't have that in the previous pregnancy.
Okay. Can you tell me about your previous pregnancy that was ended up in the 9 months?
Yes, it was term. Okay, and it wasn't used uh, after the term, and it was straightforward.
And how is your baby?
My baby is fine, 2 years now.
Fine, good. Sarah, is this your planned pregnancy?
Yes,
Okay. And you just told me that everything was fine till now, and now you have a bleeding.
yeah.
And yeah, have you used ever before the contraception method?
No, I plan to have this pregnancy.
Fine. Sarah, if you are using folic acid during this,
Yes, yeah.
yeah, any scans done on you?
No,
Okay. You are, okay. If your cervical smear is up to date and normal,
Yes.
fine. So, Sarah, pardon me if you find some of my questions somewhat intruding. If you or your partner ever treated for any sexually shared infection,
No.
fine. Let's discuss some about your general health. Are you following with your GP for any medical condition?
No.
Any operation done on your tummy or down below?
No.
Okay. Are you aware of your blood group?
Yes, it is all positive.
Okay. Any reservation for blood transfusion?
No.
Okay. And any family history of concern you want to tell me?
No.
Fine. Sarah, can you tell me about, do you smoke?
No.
Take alcohol?
No.
Or pardon me, any recreational drugs?
No.
What do you do, Sarah?
I'm a teacher.
Fine. And with whom do you live?
I'm with my partner.
If you feel yourself safe and sportive at home,
Yes, everything is fine.
and how is your mood in the last 4 weeks?
Yes, everything goes fine.
Fine, Sarah. So, Sarah, thank you for sharing this information. What you have just told me, and what I have gathered from notes, and I see in the examination findings which my colleague has just done. And after confirming that the ultrasound report belongs to you, and confirming the name and NHS number and date of birth from your ultrasound report, I may need to discuss that you have told me that this is your second pregnancy. Your previous pregnancy was quite normal, and your baby is 2 years now. Okay, and
Yeah.
now you have presented at 5 weeks with the minimal bleeding from the downward.
Mm-hmm.
Anything else you want to add?
No.
Fine. So, Sarah, your observations shows that you are stable right now. The
Mm-hmm.
ultrasound I have confirmed and confirming that it belongs to you. Right now, the ultrasound shows that the since one test is done, that is the blood test of to see the pregnancy hormone. The blood test shows the pregnancy hormone not at that level at which the pregnancy can be seen in the ultrasound. I think ambiguous in this. Let me clear this. Ultrasound report at this point there is no pregnancy seen in the ultrasound report. There are many possibilities, like it can be the very early pregnancy. At this time, the pregnancy cannot be seen in the womb. The other thing possibility is there can be uh, miscarriage, like the failing pregnancy. I'm not saying that this is right now is possible. We may confirm it by repeating the blood test, the pregnancy hormone test, after 2 days. Am I clear about this?
Yes, doctor, you are clear.
And the third possibility we can see is the pregnancy which is not inside womb, that can be outside the womb in the tubes. To rule out and to see what type and what is actually going, we what we will do right now, we will repeat the test, the blood test or pregnancy hormone test after 48 hours, and we will see if the level of this hormone is increasing, remains sustained, or decreasing. On that it will be decided. If the pregnancy, the hormone will be doubled, it means that your pregnancy is quite normal and growing, and it will be soon seen in the ultrasound report, and we will repeat the ultrasound report after a week. Okay. And
Okay.
the other way, in the if case the pregnancy hormone level is decreasing, then in that case there is the possibility that the pregnancy is not growing, and it is going to the miscarriage. Fine. The
Yes.
third possibility that can be, if the pregnancy hormone is between the less than becoming double, there is a possibility the pregnancy is somewhat outside the womb. In that case, we may need to have some management plans for you that we will discuss later. Any
Mm.
concerns and questions you want to ask?
No, doctor, is it clear? It is clear now. Okay.
So right now I will give you the written information about your condition,
Okay.
and I will also put you in contact with the support group. Meanwhile, while going to home, if you ever feel dizzy or feel like having a heavy bleeding or shoulder tip pain, I'm giving you the 24/7 contact number. You have to immediately come to the hospital, as that can be the sign of some sinister condition, like we are discussing ectopic pregnancy, the pregnancy outside the womb. Okay, or this can be, if you are having a heavy bleeding, this can be leading to the miscarriage. So at that time you have to immediately return back, and if all the things are okay, you will come 2 days with the report of the test, and we will discuss that report with you. Okay, right now I am writing back to your GP about over today's discussion, and I will also arrange a meeting with my consultant for your further management. Is it okay for you?
Can I end this pregnancy, doctor?
Yeah.
Can I terminate this pregnancy?
Why you want to terminate? Can I know?
I'm very worried, and I don't want to continue this pregnancy. Can I terminate this pregnancy now?
Sarah, but yes, I respect your wishes, and need to know more about why you want to end this pregnancy. As you told me, this is your planned pregnancy. Is there any special reasons that you want to tell
Yeah,
me?
because it may be outside and it may cause problem for me. So I wanted to finish. I wanted to end this pregnancy because I don't want any complication.
Yeah, Sarah, I understand your concerns as you told me. Sarah, can I, but we will discuss. I want to reassure you, will be remain us. It will be quite confidential. Can I told you, do you have any problem like having a less support at home regarding your pregnancy and your upcoming child?
No, no, not at all. Everything is fine.
Okay, so can you explain in a more detail why you want to terminate this pregnancy? If due to any other your health condition?
Time finish. Okay, nothing at all. Only I have time and I want to ask you some question before the time because I still have time. Don't worry, Dr. says that it is not domestic violence or nothing, no hidden agenda at all. Don't worry.
Actually, you asked that is a planned pregnancy, and then later
Yeah.
you say that you have to terminate this pregnancy. And I was
Yeah.
surprised why you want to terminate when this is a planned pregnancy.
Yes, yes, no hidden agenda at all. Don't worry about that. Only because I still have 1 minute and I want to save this time or to get benefit from this time. No problem at all.
Yeah.
Okay, so anyhow, the patient cannot be offered termination of pregnancy. Okay, even if it was unplanned pregnancy, this patient cannot be offered termination because we have to first check that the pregnancy inside the womb and it is inside the uterus, and after that we can discuss
Yeah.
termination. Okay,
Yeah.
so this patient we cannot offer here. Yes, sure, we can offer termination. No, 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 at all. This pregnancy of unknown location, we don't know where is the pregnancy itself. Maybe miscarriage, it may be ectopic, and it may be a normal pregnancy. So after we check that the pregnancy inside the womb, and we can come and discuss this again, we can offer and discuss the termination, the method of termination after that. Okay, thank you very much. You did the task in a very good way. Okay, amazing. But I surprised how you can forget to ask about the details of history present illness to check about the fainting attack and the pain in shoulder and uh, any dizziness to check whether she has an ectopic pregnancy or no. Okay, your performance was excellent, but you missed this small point. Okay, take care of this point. It can be considered as safety. So yes, histopathologic illness. You ask about the pain and bleeding. Ask her about any pain in your shoulder, any dizziness at all, any fainting attack. Okay, this will be also to be sure that she doesn't have an ectopic pregnancy. This is a pregnancy of allow location, so still there is a possibility to have an ectopic pregnancy. The remaining history is amazing. You ask about the gynae history, Anything else? Nothing. Okay. A contraception and the period smoking, support at home, everything was very good in the history taking. When you come to explain for the patient any result, confirm the identity of the patient by the name and the NHS number. Okay, so this is Sarah Jones, NHS number 1234 or date of birth 1234, and explain for her. And if you are in face-to-face exam, you have to draw for the patient. Okay, you did it in amazing. You use a lay language in a very nice way, but check understanding more often. Okay, you need to check understanding more. So you explain the possibility of the patient of the case. What may be this may be ectopic pregnancy, and it may be miscarriage. It may be normal pregnancy, and it is the scan done too early, so it will appear later on. So this patient need to offer the more investigation and more follow-up, like to repeat the beta SG. You didn't talk about the cyst at all. Okay, so take care. Still have a cyst, it's a clear cyst in the right ovary. It may be corpus luteum cyst, and it is maybe reassuring signs. Okay, this can happen even with normal pregnancy. So you have to explain this cyst also to the patient. Take care of this point. So what is the suggested plan for this patient? This patient need to repeat the pregnancy hormone beta HCG after 2 days. Okay, and the possibility if the beta HCG rise, it may be normal pregnancy. If it falls significantly, it may be miscarriage. And if it slightly rise or stay in the same level, still have the possibility of ectopic pregnancy. She may be offered another scan after 1 to 2 weeks, and according to the result of the tests and the scan, her management plan will be decided after that. This patient, the good thing is that you give her warning sign because she still have a risk of ectopic pregnancy. So if she has a bleeding, she has any pain, she feeling unwell, feel dizziness, any pain in shoulder, okay, she should come back to the hospital immediately. Give her some patient information leaflet to read about the pregnancy of unknown location. Okay, and give her contact number where she should contact if she has any queries. Thank you, Dr. Asidra. Dr. Antisar, are you with us? Dr. Antisar?
Yes, sir. I'm here.
Okay, good.
I'm here, sir.
Okay, good. I can hear you well, so. Try to bring something easy for you, Dr. Ansar. Okay, I'll just 2 minutes for you.
Okay.
2 minutes started.
There is another slide. Oh, yeah.
When you're ready.
Okay, sir.
Okay. 10 minutes.
First slide, please.
Start.
Hello, I am Intisar Abdul Qadir, one of the exam candidates. I have read the scenario. I'm ready for the structured discussion.
Okay, Dr. Charles, can you interpret this MRI, please?
Yeah, this is a sagittal suture in the MRI of the pelvis. Uh, of a lady, which is showing that the uterus is occupied by multiple fibroids.
Okay. So could you tell me,
Most probably, yeah, most probably. Yeah.
okay, how you will manage this couple?
Yeah, management, actually include two words, actually, diagnosis and the treatment. So in order to diagnose the problem of that couples, so I have to ask the wife and the husband, or the wife and the partner. So the wife, I will ask her about, as I see a scenario, she has a primary 44 years and primary infertility. So I have to ask her that about her periods, whether they are regular or not, and when was last period exactly, and for how long she is trying, her and her partner, for to have a baby, and what are the investigation done, and what are the treatment, if she received any treatment before, and and if this those investigation here in the scenario are the first time they do those investigation, because actually it showed that the husband semen is normal, the hemoglobin of the patient is normal, tube is patent, and she is likely to be ovulating, progesterone is 37, and FSH slightly little bit higher but within normal range. And then coming to that multiple fibroid uterus, it seems that the uterus is bulky and enlarged with occupied by that fibroid, which is situated in different side of the wall of the uterus. And I would ask about if this fibroid has any complaint for her, for example, pressure symptoms over her urinary bladder, so that she want to go to the toilet very frequently, rush to the toilet, or maybe she's coming of stress, urinary incontinence, or leaking urine upon any stress, or involuntarily. And also I'd like to ask about that effect upon her periods. Her period is it affected by those fibroid, about the amount of the period? Is it heavy, even prolongation of the days of the period, and for how much it changes her pad, or it doesn't have any effect on the period amount and days? And then I will ask her if there is any tummy pain, any tummy pains that accompany the presence of that fibroid and nature of that pain will refer to any. Does she know about that fibroid before? Does she seek any medical advice or took any medications for to decrease the size of that fibroid or not? Then I will ask her about general cases, like general questions like her sexual history, and to ask about whether how many times per week, any complication during the sexual act regarding erection, ejaculation, regarding the female, if she has a desire for sex or not, any complication about the sexual history. And I will if her husband is fathering a child before or not. And I will ask her if she has a general medical condition she received treatment for, any surgery before, allergic to anything, special habits like smoking, alcohol drinking, recreation drugs, cervical screen. What about her cervix? Updated and normal. Whether she is feeling safe with her husband and she is well supported. Any family history of concern, like similar condition like that fibroid before, any or similar history of fertility or primary infertility in family, and what are the cause for. Also the mental history of the patient, because this is a case of infertility. Also it is important to ask about the mental history.
Okay, this is the history of the patient.
Yeah. Yeah, the history seems that there is nothing wrong about the history as regarding all the questions needed to be asked.
Okay, so could you tell me what is the most likely diagnosis of this couple?
Most likely,
Of the cause of the infertility? What is the most likely cause?
yeah, in those couples, most likely it is a case of unexplained infertility. Yeah, there are a huge multiple fibroid uterus in that female patient, but it seems that doesn't affect anything in the female patient. So
So
that is
will
to
you
say,
offer her
most probably this is
will you offer her
sub-serous.
the removal of the fibroid or no?
Actually, the guidelines has been actually conflicting opinions about that. They said that that if the fibroid is subserous, so nothing to do with the infertility. So no need to treat. No treat unless, especially when it is asymptomatic and no pressure symptoms. If it is intramural mural fibroid, there are conflicting results. Actually, some guidelines say to say, or some papers say to remove, some other not to remove. But the issue what is actually ensured by the guidelines, that the submucous fibroid, if it is present, especially if distorting, if affecting the menstrual history, and it is well apparent in the cavity of of the uterus, so it should be removed before, in any case of subfertility.
Okay, so what are the options of this couple?
Yeah, the option of these couples actually, as long as yeah, it looks a big fibroid, but it seems that no effect at all. So actually, we have to consider this is a case of unexplained infertility, and we should refer it to um, an IVF center for test tube baby, and also taking the advice of the fertility center about such a fibroid, and it's maybe they have another. Um, but I have to tell those couples that NHS funding of this IVF trial maybe not be accomplished, because the patient is 44 years, and um, uh, what else? I'm sorry, I didn't ask about her body mass index, because it's above 30 also it will not be funded.
Okay.
So, and I I mean, this case, the patient and her couple need a multidisciplinary team. I mean, group of doctors to discuss their case, especially with the presence of such a big fibroid or multiple fibroid uterus. So that this include the obstetric consultant, the fertility specialist, and so from a fertility center or IVF center specialist, also specialized clinical nurse, and to actually discuss with the patient about test tube baby and in the presence of such a fibroid.
Okay. Any other option for this couple other than the IVF?
Yeah, it could be surrogacy. It could be here surrogacy. Maybe we can do it, but it will be in the form of partial surrogacy, taking the eggs from ovum from the mother and together in the to be and fertilized by the sperm of the husband into the labs and put it in the womb of a surrogate mother, or adoption, or
Okay. So how much is the success rate of the IVF in general and specifically for this couple?
in general, it is no more than 30% actually, and in those couples actually because of the age of the patient. And I don't know about the age. Also, when the partner is more and more older, also this affect fertility, and because of those fibroid uterus, yeah, it is less likely. So it will be maybe 10 to 15%.
Okay.
And because the patient, even if pregnancy, have been liable to miscarriage, high incidence of miscarriage and maybe congenital anomalies of the baby. Yeah, it is not without a risk actually, pregnancy in her age.
Okay. Okay. I finished my question. Do you want to add anything?
Yeah, actually, the decision of the couple, the decision of the woman and her husband is really very important about that fibroid, whether to deal with or if not to go to the assisted fertility. Yeah.
Okay. Thank you, Dr. Ansar. Well done, Dr. Ansar.
Thank you,
Thank you.
sir.
Thank you very much. You excellent, Dr. Ansar. You managed to answer all the question in a very nice way. I only I want from you to talk about the counsel the patient about the pregnancy in the age over the age of 40, the pregnancy in the age over 40. So you should also counsel the patient beside the foundation by the NHS. You should to counsel her about the complication that may happen in
Yeah.
case of the pregnancy over the age of the 40. And also you mention also the pregnancy in the case of fibroid, but you may mention some of these complications that may happen in the pregnancy when the patient was fibroid. That's it.
Yes, sir. Yes, sir.
Other than these 2 points, you did excellent in this task. So you interpret the result of the MRI or the MRI in very nice way. It seems that it is mostly fibroid uterus. Okay, so how you manage this couple? As you mentioned, management means diagnosis and they go to the suggested plan. So I have to reach to accurate diagnosis from where? From the history, examination, and the investigation. So the patient already has some investigation done. So I wanted to take a history. This history can be done from the patient itself and from reviewing the patient's notes. So as infertility or subfertility, we should ask about four things. About the history present illness, which is the fertility or the infertility, and sexual history, ask about the partner, and ask about the patient. So this should be done in the subfertility template. So the template of the subfertility module should be include these four items: history present illness, sexual history, patient, partner, and patient. You ask that, very good. Ask her for how long she tried, if for any treatment, and the good thing that you didn't miss to ask about the fibroid, the symptom of the fibroid, the pressure symptoms, the bleeding, intermenstrual bleeding. Also, if you can ask about loss of weight, loss of appetite. Sexual history, to exclude any coital factors in this subfertility issue. How often, and do you have any?
تخيلي انا فكرت كلها يعني ده هيموت.
Okay, so partner, if you ask about the partner, is he fit and well? Has he father initiated before? It will be more and more amazing. Then go to the patient itself, ask about everything in the patient: gynae history, obstetric history, cervical, smear, medical and surgical history. Okay, so this is the template of the subfertility. Any case of subfertility module, you should cover these four things. Then the examiner give you a brief of the history. You may read it in your a silent way, or you can give the examiner a summary of this history. So from the history, the patient is married since 3 years, no problem with sexual intercourse, no symptoms of the fibroid. Last semester her cycle is regular, last one since 2 weeks. She is fit and well, and she doesn't have any concern. So what is the likely diagnosis of this couple? As you see, as Dr. Ansar said, as the ovulation is normal from the progesterone, the tube is normal, okay, by the HCG patent tube, semen analysis is normal, so it seems that it is it is unexplained infertility. And we have to tell the examiner like that, not only unexplained infertility and that's it. No, you have to tell him that the ovulation is normal, seen in the progesterone and the normal cycle of the patient, and the patient has a normal or patent tubes by the histopictogram, and the partner has normal semen analysis. So it seems that this couple have unexplained infertility. So the next question will come: will you offer removal of the fibroid for this patient? Yeah, here, as Dr. Ansar mentioned, the guideline or the recommendation for removal of this fibroid is debatable. So the guideline, the NICE guidelines, say that if it's submucosal only, submucosal fibroid, in otherwise normal patient, otherwise everything is fine, everything exclude everything, okay, so we can remove this submucosal fibroid. Subserous not affected the fertility at all. Intramural is still uncertain, but submucosal fibroid can affect the clinical pregnancy but not the live birth rate. The Canadian guideline say that it is mentioned there in the talk, very nice talk called pregnancy with fibroid. Okay, this is very nice talk, to be honest. I mentioned that if submucosal fibroid in otherwise unexplained infertility, so you exclude everything and still only submucosal fibroid, so you can offer the patient removal of this fibroid, and the 2/3 of the patient can conceive after abdominal myomectomy if all other causes are excluded. So what is the option of this couple? Okay, so the examiner asked about the option of this couple. Okay, any patient with unexplained infertility for 2 years should be offered the IVF. But the concern here, we have to counsel this patient about the foundation by the NHS, because it is 44 years and the NHS not found this any patient over the age of 40. And sir, we have to counsel her about the complication of the pregnancy over the age of 40. Okay, so there is some risk of the mother, like thrombosis, like gestational diabetes, hypertension, increased rate of cesarean section, and there is some risk of the baby, like stillbirth and miscarriage, chromosomal and preterm delivery. Also, there is some risk of the complication of the pregnancy in patients who have fibroid, big fibroid like that. It may have a failure to progressive labor, placental abruption, and postpartum hemorrhage. Also, the baby may have a preterm or PPROM on presentation. Okay, so this is some more details I added it from the talk. If you wanted to know it, it's okay. If you don't want, it's also okay. In case of structured a separated patient task, what you would say regarding to the mode of delivery and that. So the surrogacy, the second option for this patient is the surrogacy. Okay, we have two types of the surrogacy. Okay, to make it clear for all of you, full surrogacy contain IVF cycle. What it mean? So full and partial. Full contain IVF cycle. So we will do induction of ovulation, stimulation of this patient, collect the ovum of the egg of the patient, and fertilize it by the partner semen and inject it to the surrogate mother. So the baby will be genetically linked to the original mother. Okay, this is the full surrogacy, contain IVF. Okay, in the partial surrogacy, we will take the semen and of the partner and inject it directly to the surrogate mother, artificial insemination. So partial artificial insemination. So the baby here will be not genetically linked to the original mother. It will be better here because, okay, if we do IVF cycle, still we take the egg, it will be poor character or poor quality and egg. So we wanted to do the partial surrogacy So we'll use only the semen of the partner. The last option is the adoption. The last question by the examiner was in the exam, how much is the success rate of the IVF in general? It is 20 to 35%. And how specifically for this couple, the IVF success rate decrease with the age. It will reach to 5% after the age of the 42. Okay, so by this 42 years, the success rate of the IVF will be dropped to 5% only. Some notes also I took from the TOG article about the antenatal myomectomy, when we should do antenatal myomectomy, when we should do cesarean section myomectomy. There is some criteria for that and that. Okay, you can go and read for this. Please comment on this, please. What is it? Yeah, her FSH is high. Yes, FSH is high because of her age, but it did not affect her ovulation. What we can do, what we should do, what do you think about the FSH? What we should do for her? Okay, so her ovulation is normal, her progesterone is normal, and the cycle is normal. So what we should do? Anti-Mullerian hormone for what? For anti-Mullerian hormone for what? For ovarian reserve. This is the job of the fertility center or the fertility specialist. I know for ovarian reserve, it is the job for the fertility specialist who we offer her the IVF if she accepts after counseling her about the foundation, about the age, about the complication of the fibroid, the pregnancy with fibroid. Okay. Okay. Thank you for all of you today. It was a great honor to give you this session today. I hope all the best for you in November. We'll try to arrange another session to give the chance for the other people who didn't share today. Please feel free to ask me on the group, on the STEP group, if you want to comment on any station, if you wanted to discuss anything. Okay. And thank you for all of you. Thank you, Dr. Ahmed. Thank you.
Thank you,
Dr.
Dr. Ali,
Ali.
for
Thank you.
Thank you, Fatima.
Thank
Thank
Dr.
you.
Ali. Excuse me.
Hello,
Yes.
sir.
Yeah.
Hello.
Can you
Sir, I
show
have
us
one
that
question.
past cases, please?
Only,
Slide only.
hello.
Yeah.
I have one question. In case of only intercavitary fibroid, we have to operate
Intracavitary submucosal.
submucosal, yes.
Yeah, we according to the guideline and the TOG, they mentioned if we exclude everything, so the tubal factor is normal, the ovulation is normal, the semen analysis is normal. After excluding all of this, if it's still only we suggest that this is the only cause in the patient, we can remove this submucosal fibroid.
Okay. And if it is showing that intramural fibroid is distorting the endometrial cavity, in that case,
Yes, they talk also about this point regarding the intramural fibroid. It will be according to assessment of the uterine cavity, and it will be case by case. So it will be not agreed plan for all the patients.
individualized.
Yes, individualized. Okay, not for all the patients.
Thank you so much.
Thank you. Thank you very much. Thank you for all of you.
Dr. Ali, can you
Yes.
show us first slide, please? First case slide.
Okay.
Thank you very much.
This one?
First case.
First case. I will
Yeah.
send the record. If it
Okay, thank you.
if it make any sense, okay, I will send the record. If you want to take, this is the first case I discussed today.